All right, so chapter 9, again, is the respiratory, hemic, lymphatic, mediastinum, and diaphragm. And so, of course, this is AAPC's presentation. Our objectives for tonight is to understand basic anatomy of the organ systems mentioned, as well as defining key terms, talking about codes and modifiers. So, being that, we're in an organ system where we have multiple or pairs of organs, like we have two lungs. Um, we'll be talking about use of proper modifiers, as well as reviewing diagnoses, common conditions of those organ system, and Hicks-Picks level 2. So starting with the respiratory system, and this is the same exact information that you see in your tabular list. The organs that are involved there are the nose, larynx, pharynx, trachea, bronchi, bronchioles, and lungs. And so the respiratory system consists of these organs that provide air passages in lungs, supplying oxygen and eliminating carbon dioxide. And I can remember as a kid, in science class, that was one of the, or health class is what they called it. That was one of the first things that I remember learning, and I was so mesmerized and intrigued that I wanted to be a scientist when I grew up. Who knew I would end up to be a medical coder? Totally not the same profession, but there's a linkage because learning biology is a big part of understanding organ systems. You start with an organ system. You start with an atom. An atom makes cells. Cells, a group of cells is called tissues. A groups of tissues make organs, and then groups of organs make your organ systems. So it all, really links together in understanding that and working in healthcare, specifically being a coder, because we have to have the same knowledge that the doctors have, which is why we're so valued and why coding is in such high demand, because they want people that are knowledgeable about the same thing that doctors are in order to capture the revenue that they want to make. So, um, oxygen. So, yeah, our lungs are supplying oxygen and eliminating carbon dioxide, which is rich, excuse me. Oxygen rich air moves out of the lungs as waste, and then the respiratory system contains the upper and lower respiratory tract. So, just like that's why we can have an upper respiratory infection, because the upper respiratory tract consists of organs that are located outside of the chest cavity. That would be the nose, the nasal cavities, the pharynx, larynx, and upper trachea. So that's all your throat stuff, located outside of the chest cavity. And then the lower respiratory tract consists of our lower trachea, bronchi, bronchioles, the alveoli, and the lungs. The bronchi, bronchioles, alveoli, and lungs are all located within the lungs, so that makes that the lower. And then our nose includes an external portion that forms part of the face, and that external portion is called nasal cavity. So, of course, if you have a sinus infection or what they call sinusitis or inflammation of the nasal cavities, you're going to see that your face is going to be swollen, um, because that is inflamed and it makes up a part of your face. These cavities contain fine hairs that are trapping large inhaled particles and serving as our first line of defense against harmful environmental pathogens. Y'all ever heard the saying that you should not remove your nose hair? Like, that's the purpose of our nose hair, is to catch debris. Air enters the nasal cavities through the nostrils or nares, and then the nasal cavity contains receptor cells for the sense of smell. The pharynx, which is our throat, lies behind the oral cavity and between the nasal cavities and larynx. And then the pharynx directs food toward the esophagus and air to the larynx. Um, A lot of people get the pharynx and the larynx mixed up. So the pharynx is your throat, 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 and the larynx is located between our throat and trachea. The larynx is your voice box. And the larynx has three functions. It acts as a passageway for air during breathing. It produces sound as well as your voice, and it prevents food from entering breathing structures. So I don't know if I told y'all about the time that I got pneumonia because I was eating a sausage pizza. It's funny now. It wasn't funny then. But I was eating a sausage pizza, and man, let me tell you, I was really enjoying that pizza. And I inhaled a piece of Italian sausage that got lodged in my lungs and then caused me to have pneumonia due to inhalation. So it didn't feel good, but that's the purpose of when you think about all of these things, the functions of the respiratory system. So my larynx was supposed to act on my behalf to stop that food from going into my breathing structures. However, what do our parents always tell us? Don't eat with your mouth. I mean, don't chew with your mouth open because you letting in air when the air is supposed to be kept out so your food can go down, which is, you think about all of that. You swallow hard when you're drinking water, you're going to end up with gas, or, you swallow wrong and you're going to get an air bubble or choke. So all of those functions have to operate together in order for our um, organs to operate efficiently and effectively. Our windpipe, that's the trachea, is a tube about 4 to 5 inches long and 1 inch in diameter, and it extends from the lower edge of the larynx down into the thoracic cavity. It splits into the right and left bronchi. Um, this is something that y'all should probably write down. Where the trachea splits or bifurcates. So if you ever hear the term bifurcate or bifurcation, that's like it branches off. Like let me see. It branches off. So if you're looking at any illustration of the lungs, whatever you have your page open to for your ICD-10 book, if you still have it open, you'll see like inside of your lungs those little tree branches. Um, every time there's kind of like, I guess you could say like a fork in the road. That's a bifurcation. Keyword or the breaking that word down, the bi means two, right? The prefix bi means two. And so that means you're splitting into two directions. But anyway, where your trachea splits or bifurcates is called the carina, Carina. And where you see those branch-like looking structures, that is called, excuse me, that is called your bronchial tree. So even if you get bronchitis and pneumonia, which a lot of times people tend to people tend to identify them as they're the same, but they're not because they're inflammation of different areas. So inflammation of the bronchioles would be bronchitis. Inflammation of the lung itself would be pneumonia. Um, Most of our respiratory organs are concerned with movement or conduction of air through respiratory passages. We have our alveoli, which are tiny air sacs located at the end of respiratory passages, and this is where gas is exchanged. Also, oxygen and carbon dioxide is exchanged between the inspired air. and the circulating blood in the capillaries. So this is how our body, our blood is oxygenated through this process. Um, if someone has, let's say, a couple of different conditions, pulmonary hypertension, for example. So we know that hypertension affects your blood pressure, but pulmonary hypertension affects the amount of pressure that is in your blood at the time that this process of oxygenation and making sure that your blood is supplied with the right amount of oxygen occurs. And so it affects the gas exchange happening in that process, which causes a number of things. Um, it could cause a number of things. But let's also talk about the pleura. Um, maybe you may be familiar with the medical condition of or the diagnosis of pleurisy. So pleurisy is, or pleuritis, is inflammation of the um, pleural cavity that's inside your chest. So this is a cavity that is, it's in a central area, and it's a layer of I guess you could say it's almost like a fluid lined layer, but it's a layer that covers the that central part of your chest, and so it can get infected as well. People can also have an excess of pleural fluid that may affect their respiratory and cardiovascular, because it's located in the central cavity of the chest, which is where your heart is. So again, you have, conditions like an excess of pleural fluid, congestive heart failure, pulmonary hypertension. All of them, cause a lot of the same symptoms. But um, with the pleural cavity, one way to kind of think about it is if you have a partially inflated balloon and you place your fist into the balloon, the fist is going to be covered immediately by a layer of balloon. And this layer is pushed up against the outer layer of the balloon. And so when they work together, these layers are going to slide against each other. And when they're sliding, they only have a little bit of fluid that helps lubricate it. So it's a very intricate process. Our body is um, loaded with amazement in the things that it can do. Um, so the definitely I would say the respiratory, the brain, the respiratory, and the cardiovascular systems for me are the most intriguing, just to even understand how they work. Um, when they work well, when you can consider the multitude of things that can cause them to not work properly, um, it really is a miracle, just thinking about it. So the respiratory system as a whole is quite susceptible to disease. It is perhaps due to constant contact with the outside world, which we've again seen with COVID, um, pollution in the air, infections. So common infections of the respiratory system are rhinitis, which think about a rhinoceros. Um, that's your nose. So rhinitis would be um, and nose or nasal infection. Sinusitis would be inflammation of the sinuses. Pharyngitis, that's just a sore throat. I shouldn't say just. Laryngitis is typically that's your voice box. So you usually lose your voice with that. Tracheitis, inflammation of the trachea. Bronchitis, pneumonitis or pneumonia, which nobody really says pneumonitis, but that is also another term for pneumonia. The respiratory system is also susceptible to cancer and allergic conditions, which I have. I suffer from allergic asthma because the minute I'm uh, exposed to an allergen, which I'm still learning what all of my allergens are, um, But thank goodness I haven't had any issues in the past month. First couple of weeks or months of class, it was rough for me. But things have been going really good, so I'm excited about that. But acute respiratory infections are common, like like I mentioned earlier, the upper respiratory. Now, with so many other, with so many other, shoot, sorry, with so many other conditions out now, a lot of times it's very tricky in giving the appropriate diagnosis. Doctors do have to order more tests. Back in the day, they would just label everything an upper respiratory infection and send you on your way, right? Now they have to run tests to confirm whether or not you have this or that. So it's definitely put a strain on the medical community, as well as a financial strain on those of us who may be patients at the time. So several other diseases are listed here. Um, Lung diseases due to external agents, again, that could be like your allergies. And then you have intra-op and post-procedural complications. So everybody should be familiar with when you're in the hospital, you had a procedure, maybe even a baby, and they give you the just because I'm trying to remember what it is. I think it's a spirometer. But the thing that you blow into to keep your lungs kind of functioning and expanding properly, because when you lay down, your lungs go flat. They deflate. Even if you're, like a lot of people had COVID and they would tell them don't lay flat, because if you're laying flat, you are compressing your lungs and you're not giving them the opportunity to expand. So even, any type of respiratory condition, that's always the advice that they give. So remember that if you get sick with any type of cough or cold or whatever, that laying flat is not the best. You should definitely sleep propped up, and that will allow your lungs to be able to expand so that you can get air. Next slide. Any questions? Okay. Y'all still there, right?
Yes, ma'am.
Yes, we are here.
Yep, still here.
Present.
Okay, okay. I was like, what's happening? I don't hear anything. All right. Um, Anybody personally suffer from respiratory conditions? Okay. I am one that when I know I have, like, pneumonia is something that I've battled with for years now, um, because of my asthma. So I always know when I get sick. I know what extent it's to. So I'll go to the doctor and be like, "Hey, I got pneumonia," and they'll be like, "Oh, well, we need to do a chest X-ray to confirm." Blah blah blah. I'm like, "Why y'all don't spend my money on an X-ray when I'm telling you what I'm coming in here with? I know my body." And so you start to, kind of learn your body, with these different conditions and the difference between pneumonia versus bronchitis, the type of cough, the way it sounds, um, even, pulmonary edema like swelling, congestive heart failure, as I mentioned earlier. So I won't necessarily go through all of these conditions as far as the diagnosis coding, but I will say, oops, I keep popping all over the place. I will say, with these conditions, a lot of the, um, matter of fact, turn to your ICD-10-CM book and go to, start with asthma. I just want y'all to kind of be able to efficiently through the book. Right. So I'm on page 74 in the ICD-10-CM Index to Diseases and Injuries, and I'm looking at asthma. So when you go to the main term, you have a default code for general asthma, not identified as anything else but asthma. The default code of J45.909. But as you look further and go down, if the patient has asthma with chronic obstructive bronchitis, then you have the code J44.9. If they also have asthma and that chronic obstructive bronchitis with acute or respiratory infection, then your one code would be J44.0. So as you can see, those indentions start to become a little bit more important, but also more detailed in the things that you're coding. So you would not need more than one code for a patient with asthma, chronic bronchitis, and acute respiratory infection. You would just need that one code. Any question on that? If you see the term exacerbation, like you see under asthma with exacerbation, acute, that J45.901, that just means that they're in the middle of a current asthma flare, or a current asthma, you say crisis, but the term that they typically use is flare. Turn also to influenza. Let's go look at influenza real quick. Main term in the index. Influenza. Which is the flu. Y'all remember a time when the flu was the thing that was killing people? Everybody had the flu. We had to get flu vaccines. It was major. And then came, something worse. But the flu section of ICD-10-CM went through a lot of expansion. It really used to be a small section. And then it kind of grew to, and this is on page 225, but it grew to the different variants of the flu. So we had, where am I looking? You have your default code of influenza, which is J11.1. But if they had the flu with digestive manifestations, that would be, the flu with diarrhea, then your code would be J11.2. If you had the flu with enteritis or gastroenteritis, because the entero refers to the intestines, that's still diarrhea. Gastroenteritis, which all of that digestive manifestations, J11.2, is the same for the fluid enteritis and the fluid gastroenteritis. Also, gastrointestinal manifestations is all J11.2 with that particular code, because the stomach and the intestines, where's your intestines? Is inside your stomach. So, well, inside your abdominal cavity, if you want to be specific. But that's why they grouped that together with that one code. Now look at influenza A. So remember, or y'all, if you remember, if you paid attention, at the time they had influenza A, influenza B, influenza C, and then they had H1N1, which I think was the bird flu. Then they had H1N oh, the swine flu. Then they had the swine flu. So we had the bird flu, the swine flu, um, and then we had H5N1, which was an A variant. So point I'm making is we're seeing the same trend now, with COVID. So as the diseases mutate, the codes also have to be able to identify what the conditions are. And so that's why this book is so big, and that's why this book is going to continue to grow, because as the diseases change, the codes have to be specific enough to identify that exact disease. So again, I wanted to point out by going to influenza that there could be detailed specifics as the type of flu that the patient has. So you want to make sure that you're capturing that in your coding. Again, I'm not gonna, because I'm gonna send the PowerPoint out, I won't go over the detail of all of these conditions because I really want to get to the CPT coding, um, so we can do some practice. But I will mention here, so for your diagnosis coding, you will probably see a lot of reference to either a personal history, a family history, or screenings, where you'll have a Z code. For personal history, possibly patient has a personal history of lung cancer, personal history of asthma, um, personal history of lobectomy, which would be removal of the lung or a lobe of the lung. So you want to make sure that you're capturing those codes, adding those codes. Also, it's likely that you will see family history. So these are your Z codes, these are your status codes. So I'm gonna show y'all. Where is the Z codes? You may also see Z codes related to drugs. Like if the patient has asthma, then they may have a long-term use of what do they call it? Anti-inflammatory for the lungs, or let me make sure I'm saying the right thing. Oh, long-term use of non-steroidal inflammatory, which would be like some of your albuterol inhalers, um, long-term use of albuterol. So you may see some of those as well. Um, remember on page 1317 in your ICD-10-CM book that there's an appendix A, that is appendix for Z codes for long-term use of drugs. But for your family histories, you'll have to go to your index to diseases and look up history. And that's going to give you your family history or personal history codes. And then for screenings, if the patient is having a screening, then that means you have a Z code that can be used as the principal diagnosis or the first listed diagnosis, if that is the only testing, because the screening is a testing. So it could be like a screening for malignant neoplasm of the lung. That would be a Z code, because that may have been the only purpose of that visit for that patient for that day, that clinic day. CPT rules and guidelines. So this is great. We're getting to the CPT part because I want to be able to make sure that we cover all of the organ systems, because we have 40 more slides to do, which means if I do this right, I got 1 minute per slide. So CPT rules and guidelines for the respiratory procedures. So basically what you'll see is a lot of what we've already seen. parenthetical statements or parenthetical notes, which would be those notes in parentheses just below the code. Also, most codes are automatically unilateral by looking at your code description, meaning they represent one lung or one bronchial. So you would have to identify, the LT modifier for left, the RT for right, or by the modifier 50 for bilateral. Let's take a look at your CPT book now, and we can go to page. So this section in CPT is going to start what we call our 30,000. So all of these codes are going to start with 3. It begins on page. It begins on page, and this is the respiratory because the other organ systems are situated, that we'll talk about tonight, are situated a little bit differently. Page 217. 217 in your CPT book. So on page 217, this should be familiar. It is the table of contents for this particular section of CPT. The code range for respiratory is 30000 up to 32999. So remember, you'll see at the top of your pages in the CPT book what codes are organized or situated on that page based off of the header at the top of that book. But in that table of contents, you can kind of see how, just as we saw with the integumentary as well as the musculoskeletal system, basically the sections are laid out by anatomical site. So it first has codes for the nose, then it has codes for your accessory sinuses, codes for the larynx, trachea, etc. But under nose, you'll see those same common types of procedures. Incision, which means they're cutting into. Excision, which means they're cutting something out. They're cutting in, they're cutting, but they're removing something. Introduction means they're inserting something. Removal of foreign body means they're taking out something that's foreign to our bodies that shouldn't be there. Repair would be, for example, a rhinoplasty. That's what the procedure is called, but it is the word root rhino means nose. The suffix plasty means repair. So it's surgical repair of the nose, but basically it's a nose job, but it's called a rhinoplasty in medical terms. Destruction, meaning they're destroying something, maybe by heat, by laser, by freezing it, which is cryotherapy. So if you need a refresher on that, because that's going to be your biggest thing, is figuring out what that procedure represents. Remember, you can go to page Roman numeral 20, which is page XX. Excuse me, page XX in the CPT book, where it has that page where it starts the illustrated anatomical and procedural review. And it has that list of surgical procedures by suffix: synthesis, ectomy, ostomy, otomy, oraphy, opexy, oplasty, and otripsy. So always use that as a reference. So let's go to the nose, starting with the nose. And I'm going to kind of zoom through some of these, as I mentioned, just so we can cover all. The nose section, starting with the drainage, it has it has 2 procedures under incision. So remember the nose. So the way that they have these anatomic sections laid out is literally from, I would say, from the entry point of the respiratory system to the final organ or step involved in the respiratory system. So kind of from head to chest is how they have it listed. So our nose is first, then our accessory sinuses, then our larynx. So it's literally the same way that air would flow through our body is how they have these sections listed out. So it starts with, again, the nose on page 219. If you turn to page 221, the red headings is letting you know where your organs stop at. So that's accessory sinuses, or start at, sorry. If you look at, let me hit on this real quick. So with excision of the nose, this could be where you find codes for your biopsies as well as your nasal polyps. So a polyp is a growth protruding from a mucous membrane in a body cavity. Like you can have polyps in your colon, but also in your sinuses because it is a mucous membrane, meaning it's lined with fluid or mucus. So it says you would need to use modifier 50 to build bilateral. Also that the polyp removals are identified as simple or extensive, and that'll be based off of the documentation. And then one or multiple polyps removed, you would report the code one time. So if you're looking at nose excision, yeah, so look at CPT code 30110 and 30115 on page 219. Only reason I wanted us to look at this one, just as a reminder or refresher, is that in 30110, the code has nasal polyp, and then it has the S in parentheses. So whether they did one or multiple, if this was a simple excision, that would be the appropriate code. And then for the extensive would be 30115. So paying attention to your words, your letters, and your details in the code description. I mentioned this already, that if they're doing a destruction, that it could be by laser, by cryotherapy, or electrocautery. Cysts can also be removed in an excision, as well as bones from the nose or from the sinus area. That could also be included in the excisions. Total rhinectomy, the suffix ectomy means removal. So that means they're totally removing the nose of a person. Of course, only in extreme cases like deep cancer of the skin or a bad case of frostbite. Never heard of it though, but it's good to know that they have a code for it. Other procedures in the nose are introduction. The examples they give are a prosthetic for deviated nasal septum. Definitely have seen that, or removal of a foreign body, where you see removal there. So, think about children, they stick anything up their nose. So the only difference in the foreign body removal codes is whether it was done intranasal, meaning if it was an office procedure, like if they were just able to stick tweezers up there and grab what was lodged in the nose, or if it was done in an operating room that required anesthesia. So that's the only distinct difference in selecting your foreign body codes. I mentioned rhinoplasty earlier, and I talked about plastic surgery as far as cosmetic was concerned, but other reasons that they would do it would be like to repair a cleft palate, which would require reconstruction and grafts, and then a septoplasty if they're repairing a deviated septum, or a fistula of the nose. Those are some other types of repair that would be performed. Oh, control of epistasis. So this is a fancy word for a nosebleed. Um, with this particular code, again, it will be identified as simple or complex, depending on how or the extent of how they would have to. It says the approach, but approach really means the method by which they had to stop the bleeding. So if they had to fracture a bone in order to go in there and stop the bleeding, then they certainly would do that. And there are CPT codes to represent that. Incision. So what I'm gonna do is incisions. So incisions can either be done open or closed. So an open incision, what do you think that means? That means that they're actually cutting into a body area. But if they're doing it endoscopically, then that means that they are using a scope. And so they're not necessarily cutting into the person to access that point, but they may have to do some type of cutting once they're in and have use of the camera, maybe to do like a biopsy, um, or biopsy, removing a polyp or a drainage. So that could be one method that they would utilize. And so you can see on page 222 in your CPT book, where it has a section of guidelines for endoscopy. And that just simply means, remember I said if you see scopy or scope, that they're using a camera to help them visualize and see to that target area, because really they can't see up our nose without that type of assistance. Endoscopy procedures always include a diagnostic endoscopy, meaning um, they're going to do an endoscopic procedure, a view, to see what it looks like before they perform the surgery, to make sure they're, targeting the procedure at the accurate site. Then they're going to use it for the purpose of the surgery to make sure they can see. And then after that, they are going to do another endoscopy, which would be considered a diagnostic as well, to make sure that they correctly perform the procedure. So you would not bill a diagnostic endoscopy separate, because they have to do that in order to make sure that the procedure is performed on the right area and correctly. And you'll also see that is mentioned. I'm trying to make sure I see where it is in those guidelines. Oh, on page 222 under endoscopy is that very first sentence. A surgical sinus endoscopy includes a sinusotomy, meaning they're making a small incision when appropriate, and diagnostic endoscopy. So they have to do, they may have to do a small incision so they'll have the right access point to put the camera into. So that's going to be a part of the procedure, so you wouldn't need separate codes for that. So I'll definitely highlight that. So what I'll do is go through the procedure types for the nose, and then as we get to the different organs, it'll pretty much be the same type of information. Also with endoscopies for accessory sinuses, for example, so we just talked about the nose, and now we're on accessory sinuses. So same types of procedures, if they're using a camera, they need to see. In order to perform biopsies to get into our sinuses, they need to see. So look at, again, page 222 in that illustration under sinus endoscopy. We have a maxillary sinus, an ethmoid sinus, a sphenoid sinus, which, you know, when you have a sinus infection, sometimes you feel like you could be, I won't say near death, but it can be pretty rough. And this is why, because we have multiple sinuses in our nose. And so if one is infected, you can bet money that the others will too, because they're so closely located together. Again, which is why a lot of people's faces is going to be swollen, because that's inflamed if it's infected and congested. Um, and the cavities are they're deep they look, may seem small, but they're deep cavity spaces, which is why sometimes you feel like no matter how many times you blow your nose, you can't empty it out, because it's so much that can be in there and in multiple areas. So another reason they'll use endoscopy is repair of a central sinus. I'm sorry, that is cerebral spinal fluid, CSF leak is cerebral spinal fluid. So they may have to go through the ethmoid region, if you kind of see where that's located, because our sinuses drain, right? And when they drain downward or backward. So where's our spine? It's in our neck. It starts in our neck. And so you can have spinal fluid that is leaking due to a defect with your sinuses. As a matter of fact, a young lady that I know had a COVID test, and they punctured her sinus cavity, which caused uh cerebral, I don't know why I keep wanting to say central, cerebral spinal fluid to leak out of her brain. And she didn't realize it until she started having chronic headaches, and they did all this testing, and that's what they discovered. And she had to have brain surgery twice to repair that. And this is somebody I know pretty fairly well. And that is what happened to her. And that was early on when they first started doing the COVID test, and they were like just jamming those swabs up people's noses, because our clinical staff, you know, doctors and nurses, that was new to them too. They didn't know how to do that. And so they thought that they had to apply a lot of pressure and go so far up. And now they realize that they don't necessarily have to go that far or be that aggressive with the testing. Um, So anyway, the larynx. So we're going into different organ systems. So as you can see, the larynx, you still have in following along, I'm on page 224. So you still have, and the larynx is your voice box. Um, your pharynx is your throat. So, and then you have surrounding tissue, even nerves. This is a heavy populated area where there's a lot of nerves, major nerves, I should say, that would affect your ability to talk, your ability to swallow, your ability to digest food. So all of that, again, it works together. Um, and that was one of the things, you know, with when I had my tonsils, not my tonsils, my thyroid. Also tonsils, though, you know, they have to be really, really careful in this area of the body. Um, So yeah, with the larynx, you have excision. So the major thing there is the approach, whether it was lateral vertical, so that would come in at like a diagonal type angle. Anterior vertical, which would come from the front, because anterior means front, and then anterior lateral vertical, which would be a different type of angle, hard to describe, but is all we need to know for coding purposes is the surgery note or the op note is telling you what angle was utilized to make that incision or make that cut into the patient, so that they could access those sites properly. So that would be the deciding factor in your code selection. Excision, always includes a tracheostomy. So look at your suffix. Ostomy means they're cutting into. So in order for them to excise or remove something, they have to cut into it, like the not saying duh at y'all, I'm just saying duh at the, the term itself, just to kind of help memorize. So anytime you see ostomy, that means that's otomy, sorry. Otomy is cutting into. Ostomy is creating an artificial opening. So like your colostomy bags, your tracheostomy, that's creating an artificial opening, which you have to excise or cut into in order to access that. So makes sense. Neck dissections, when they say that they're doing a neck dissection, they're typically talking about lymph nodes. And so the distinction there would be, um, was it radical? This would be radical, meaning they took out everything. Um, that they took out all of these things in one surgery. That's what would be considered radical. And the only reason they would do all of this in one procedure would be because the patient had cancer. And they wanted to make sure that, because cancer can spread right to your lymph nodes first, so they want to be sure that it doesn't spread. So they just take out all of that, the muscle tissue, the jaw, the chin, they remove it all. Anytime you see that term radical, because you will also we also saw it with mastectomies, like if they're removing the breast and the lymph nodes around it, that would be considered radical as well. The larynx, so introduction into the larynx. This is another good slide. This would be like your intubation, emergency intubation in particular, like when you're having surgery and they gotta and you're having surgery, and they have to intubate you so that you can breathe during the procedure. Or if they need to change your tracheotomy tube, that would also be considered an introduction because they're introducing something to the body. Um, Again, you see endoscopy for the larynx. Here, two key things. So let me make sure, because I don't think this is, you're going to need to write this in your CPT book. It's in your textbook. So go to page 224. Two things you're going to need to know about the larynx CPT codes, because you have a set of codes for a laryngoscopy indirect, uh, and then you have laryngoscopy direct. So the difference is direct visualization means that you're viewing the anatomic structures via a bronchoscope that was inserted into the laryngoscope. Wish they had a picture. So you're using a bronchoscope, which is a scope for the lungs, and then they're putting another scope or camera inside that bronchoscope, and that would be direct. Because I'm thinking if they need direct view, then they need it to be more magnified, so they have to use two scopes. And if I think about it like that, it makes sense in my head. Um, the indirect visualization means that they are looking at the um, the larynx through a mirrored reflection. So uh, that would be like you taking a selfie in the mirror in the front of, with your phone in the front of you so you can see what you look like on the back, right? Like sometimes I do that if I want to see the back of my hair. After I get my hair cut, I'll take a selfie, but I'll do it in the mirror so I can see the reflection in the picture of what the back of my hair looks like. That would be an indirect because I can't directly look at the back of me, right? So I have to do it indirectly by taking that picture, that mirrored reflection. So I'll give y'all a little bit to write that down. Any questions thus far? Okay. Um, Endoscopy is continued here, but I'm going to run through. If I see anything different, I'll make sure I stop and explain it. But a lot of these procedures are going to be familiar or the same for each organ. So there's the trachea and bronchi, and you can see it starting there with incision, with endoscopy. So this is where your bronchoscopy procedures, because they're inserting a scope so that they can see the bronchial area, which would include lung biopsies, foreign body removals, stents, or catheter placements. But same guidelines, would apply as for any other procedure where they're using a scope. A bronchial thermoplasty treats severe asthma. They've never given me this before. But if I have a next flare up, I'm going to start asking more questions like, what's up with the thermoplasty? Can I get that? Um, and the pneumonia vaccine, they've never given me that either. Introduction for the trachea and bronchi would involve catheterizations, aspiration. So an aspiration in this sense would be like if somebody has fluid on their chest and they need to remove it or draw it out, um, which they could, leave put in tubes for drainage as well, which would be an indwelling tube or a stent. In addition, they do that for oxygen therapy as well. Um, Additional for the excision and repair for the trachea and bronchi, the lungs and the pleura. Oh, I do need to talk about this. So, two new medical terms, the thoracostomy and the thoracotomy. So, a thoracostomy is an incision that they make between two ribs to access the lungs. So, I don't know if anybody else is like me and y'all watch medical shows. I'm like old school classic. I like ER. Um, it's a pretty cool medical show, I guess, from what the well, no, not the 90s. It was like the early 2000s. But anyway, it had 8 great seasons, and I still watch. I repeat that all the time. But also House. They would
Yeah,
have
I'm watching
patients.
House now. I'm watching House now.
Are you? What season you on?
Oh, I don't remember, but I'm watching it. I'm pretty far along. I think I'm in season maybe 4, maybe.
Is Wilson still there?
Yeah, Wilson is still there. House is still there.
Okay.
Yeah, and yeah, the black guy is still there too. Oh, I can't think of his name right now.
Omar Epps.
Yeah, but I was just trying to think of his stage name.
Ooh, I can't wait for you to see what happened. Okay. I've
Well, don't
watched.
tell me. No, don't tell me.
I'm not gonna tell you.
Okay then.
It's okay. I'm not gonna say
Yes.
nothing else.
Okay. Yeah. Let's get
Nothing
back
else
to the
about
lungs and the pleura, whatever. Yeah, don't tell me.
it. You'll let me know when you see it. But I love House. So I used to work with a doctor that told me, if you ever want to know, the most realistic medical show was House. He said that was the most realistic one um to watch, as far as seeing the surgeries and the things that go on in the hospital behind the scenes. So I love House and I love ER. Um, but like a thoracostomy, so they use this for uh chest tube, gunshot wounds. Somebody's bleeding in the chest. They got to get the blood out. First thing they're doing is a thoracostomy, which they're making an incision between two ribs so they can insert the tube to drain out the excess blood. Um, which looks extremely painful. But I guess if you're a trauma patient, you don't even feel, you have so much going on, adrenaline and everything pumping through your body, you probably don't even feel it because they don't have time to give them anything for it. Then the thoracotomy is when they're actually having to cut, like, open the chest cavity, because thorax is the chest cavity. So they actually have to cut the chest open to explore. Same example, could be a gunshot wound. They're trying to find the bullet, so now they gotta, like, really open. Sometimes they have to cut ribs, remove things, break ribs or whatever to get to what they're trying to get to, if they need to take a bullet out, um, or biopsy or control bleeding, or if they need to get to the heart and they need to massage it, they're going to crack that chest because they gotta put their hands on the heart to massage it. This is where it gets cool for me. But anyways, um, so I'll go back to that right quick. Thoracostomy is suffix costomy is when they are creating an artificial opening or creating an opening for the purpose of drainage, right? Thoracotomy is when they are, I'll say, cutting it wide open, busting it open so that they can do exploration to find, using the example of a bullet that they're trying to look for to remove. So they're exploring, they're looking around, poking around, trying to see what they can see until they, um, identify maybe the source of blood loss, or so that they can control blood, or if they need to physically touch the heart for massage. So I know the suffixes are very similar, but the definitions of them are different. Um, so, that's them opening the chest. Now, they may need to do a pneumonostomy. So remember that the word root for pneumono means lung. Um, and another new term, decortication, is removal of a constricting layer of tissue from the surface of the lungs, and it also allows for full lung expansion. So I don't have an example of when they would do something like that, but I can imagine if the lungs are constricted, for whatever reason, maybe dead tissue, that they need to remove, surface tissue to help with the expansion of the lungs and help with the flow of air. Then you have biopsies of the lung that can be done either by needle, so they can, put a needle with a pretty large hole on the end in there to draw out tissue, not just fluid, but draw out actual tissue samples to biopsy the lung, because, it's a pretty invasive procedure if they have to cut the chest open to go in and cut out lung tissue. So they do that in worst case scenario, but most times they'll do it percutaneous. So that means they're having to puncture the skin. Percutaneous, taneous meaning, or cutaneous meaning skin, but they're having to puncture the skin with the needle in order to get the sample that they need. And oftentimes they will use imaging guidance, like ultrasound guidance, to be able to see exactly where the needle is being inserted. Sometimes they'll use contrast. Sometimes they will use a smaller needle for the fluid, versus the larger needle for tissue samples. But the fine needle aspiration, fine needle meaning should be a good hint that it's a smaller size, and they're trying to get fluid out or cell tissue, which again is fluid. But that is how they do lung biopsies. Removal of the lung can either be done by totally removing the whole entire lung, or they will remove lobes of the lung. It's also referred to as a resection, so you could see the word resection or removal. And you'll see that in other areas of CPT coding as well. The terms removal or resection would be used if they're removing an entire organ, or in the case of our lungs, lobes. Because I believe that our right lung, and I should probably look at one of the images, but I think it's our right lung that has 3 lobes, and the left lung has 2 lobes, not mistaken. But if I'm wrong, feel free to correct me, as I'm not looking at one of the illustrations. Introduction and removal. So I mentioned earlier the course, the thoracostomy, using the example of the chest tube that they would use to treat a number of things where they may need to remove fluid, but they give another really good example here. I use the blood for drainage, but they would also use that for pleural effusion. I mentioned pleurisy earlier. It's the same thing, where there's a overabundance of fluid in that pleural cavity that they need to drain out. So they will use a chest tube in that instance. They would leave it in for several days, and it is stitched to the skin. It looks painful. Um, and if they're doing a thoracentesis, again, like an amniocentesis, but if they're moving fluid out of the thorax itself and not just in that pleural area, then they use a bigger tube, which means a bigger hole and bigger stitches. I mentioned thoracentesis and pleural drainage. So thoracentesis can be done with or without image guidance. Thoracoscopy. So there we go again with that scope. They're using a scope. These are done, typically they're video assisted. So they call it VATS, video assisted thoracic surgery. With these, they are using the camera because in the video, so it's more a better visualization in order for them to be able to see, because our lungs, it's a vital organ. So if there's anything in there that doesn't belong, it's definitely going to affect the patient. In any mass or cancer, they want to ensure that they get it out as quickly as possible, and that it's safe to remove without doing further damage to the patient. So that thoracoscopy could either be diagnostic, where there's a mass identified and they're trying to determine whether it's cancerous or not, or it could be surgical, meaning, yep, we already know it's cancer, we already diagnosed it, and now we just need to get it out of the patient. So that's the difference between diagnostic and surgical. So another term that they use for surgical is therapeutic. Again, because they know what the diagnosis is. Now they just need to treat it. And so treating it is therapy, it's therapeutic. So they'll use the term either surgical or therapeutic. Lung transplant. So this is the first time we're talking about an organ with transplants. A transplant has 3 steps. Let's turn to page. So some of the procedures that were mentioned, there are some pretty good illustrations in the book, in your CPT book. Thoracoscopy, thoracentesis, the bronchoscope, but I'm looking for a transplant. Oh, page 237. Excuse me. So these are your lung transplants. Lung transplants are mainly they are getting lungs from people who have died. That's the cadavers. That's a cadaver donor. That is someone that has died. Or is dying, I should say. Has died or is dying. Um to get a live donor transplant, meaning somebody who's just going to give up a lung and live their life with just one lung or one lobe, less lobes, is less likely. They very rarely like to do that. Lung transplants are typically by cadavers, and the transplant itself has 3 steps. So you'll see on page 237, the 3 steps are listed. Step 1 is the harvesting, meaning, it includes harvesting, backbench work, and insertion of the transplant. Those are the 3 steps of um, a transplant. When they say backbench work, what they mean, well, actually, sorry, let me back up. When they say harvest, that means they're actually taking it from the donor. Backbench work is um, prepping the donated lung, making sure that it's going to fit. Like they'll trim it, they'll clip it, they'll make sure that the vessels or whatever that's attached to it are going to fit appropriately to the new patient, the recipient. So that's what they refer to as backbench work. And then insertion, being that last step, is actually when the recipient receives the transplant. So transplant steps are always going to be the same for any organ that can be transplanted. So when we talk about heart, same process. Kidneys, same process. Same 3 steps. I think it's heart and kidneys. I can't remember if there's other organs that will be transplanted or that they have a section for distinctly. Oh, yeah, lungs, heart, kidneys. I'm pretty sure that's it. Lung collapse. A lung can collapse during surgery. If the patient is having a resection. But there's also other procedures that are performed on the lungs, like a lung lavage, a tumor ablation. So all of those would be very, very simple to code if you're just following the steps of going through the index. So always make sure you're utilizing your CPT index as the best method to kind of guide you to the right way. I know sometimes some people, you'll just go straight to the code, which there's nothing wrong with that. But if you're really unsure, then I would always say start with the index first. I didn't mention the unlisted codes because in real life coding, we really avoid having to use unlisted codes. And so I noticed over the years, teaching this course, with the testing, that AAPC really does not use those unlisted codes like that. So let's talk about a couple of the codes from the medicine section. Now, the medicine section in your CPT book, we really won't cover that until like the last couple of weeks of the course. So probably like when we go chapter 20, I believe it's chapter 20. But there are some procedures that are performed in the office, which is why they are in that medicine section. They're performed in the office, um, and not in an operating room, but they're still procedures. So those things lie in the medicine section. Some of them would be your spirometry testing. Here's some other examples: your hearing tests, eye exams. For other areas, but for the lungs, it would be like if you do see a pulmonologist, like I do for my asthma, or a critical care lung specialist, for maybe sleep apnea. Those are tests that again can be done in the office or in an office type setting, but it doesn't require you to be in an operating room, like a sleep study, like an inhalation treatment, like with your asthma, a pulse oximetry, pulmonary stress test. So yeah, those would be found in the medicine section with the CPT codes ranging. That would be those 94002 to 94799. Um, Probably won't have a whole lot of questions on that, but just need to be aware that that's where they're found. The mediastinum and the diaphragm. So very small section. I will cover that. So I have 14 more slides to go through. Y'all okay? If I knock out these last 14?
I'm good.
Okay. The mediastinum is the thorax cavity between the lungs that contains the heart, aorta, esophagus, trachea, thymus gland, and then your diaphragm is the muscle that divides the thoracic cavity from the abdominal cavity. So, um, diaphragmic herniation. So I don't know if anyone has ever known of anyone or had this, but a couple of things that can happen with the diaphragm is that it can become herniated, meaning uh what's the word I'm looking for? It could become herniated, meaning that it can have muscle paralysis. A portion of the stomach can um, or a portion of the heart or stomach could penetrate through the diaphragm depending on the angle that it goes. So it could be, detrimental or it cause a lot of issues for someone that has that condition. So this is the ICD-10-CM section for the mediastinum and diaphragm. And it's not long because it's not a large section. Um, as far as surgical procedures go, for a mediastinotomy, because remember again it's located in that kind of like that chest cavity area, but it can be accessed either through cervical approach, meaning they can go in through the neck, or I'm sorry, the back, yeah, through the neck, cervical spine, or they could go in through the thorax, through the chest. And then procedures that would be in that section would either be excisions, so if they're taking out a cyst or a tumor, because they are looking for lung cancer. So they may also do an endoscopy using that scope once again, to perform a mediastinoscopy, again to identify lung cancer. But in this case, they want to stage the cancer. So this is how they know, oh, you have stage 1 or stage 2, or stage 3, because they have performed this this procedure to identify what stage of cancer the patient is at. So usually they're taking a biopsy, they're sending it to pathology. Pathology reviews and analyzes the specimen, and then they identify the stage. Um, One second. So if you're looking for a page number, If you're looking for where this section is located, turn to page 339. I'm sorry, I probably jumped this slide. So the mediastinum and the diaphragm section is located on page 339. So we don't have a tab for that. You may want to use one of the blank tabs if you still have some. And then the next section, so again, that's page 339 for the mediastinum and diaphragm in your CPT book. So you may want to label that page or fold it down for right now. And then the next section of CPT, because that's located behind cardiovascular. But the next one is the hemic and lymphatic system. And we're running down on the slide, so I'll be done very shortly. But the hemic and lymphatic system begins on page 334. The lymphatic system is kind of important. So it's a network of channels that carries clear fluid to and it includes our lymphoid tissue. So this is where we're talking about lymph nodes. Lymph nodes are very susceptible to cancer. Lymph nodes, their purpose is to filter our body from toxins, from anything that can cause infection. And because it's clear fluid, a lot of times it's not identified until the infection occurs. And then the consistency or the color of the fluid begins to change. So structures that are dedicated to circulation and they're dedicated to circulation and production of lymphocytes would be our spleen, our thymus, and our bone marrow. Bone marrow is the housing place of blood formation. We talked about this before. And so if someone has leukemia, it's going to first affect their bone marrow, then their blood, throughout their entire body. So that's what makes that condition so very harmful to the body. The spleen has a very important function as well because it helps the body filter out fluid that goes to the bloodstream. So we see this a lot with gunshot wound patients who have abdominal gunshot wounds, or people who are in car accidents and like the steering wheel, slams into their abdominal area and maybe crushes or injures their spleen. It's one of the organs that, if it starts to bleed, the patient is probably going to bleed out because it is it's soft tissue and is loaded with, blood. It filters the bloodstream. So if something happens to the spleen, then the bloodstream is wide open as far as infection is concerned. And then the thymus, which is a part of our endocrine system as well. Some of these organs, a lot of our organs have multiple functions because they operate in multiple systems. So our lymphatic system has 3 interrelated functions: the removal of interstitial fluids from tissues. It absorbs and transports fatty acids to the circulatory system, and it transports antigen presenting cells to the lymph nodes. Hence why our lymph nodes swell when it's trying to help our body fight off infection. We heard our antigens used a lot with COVID, and that is because they were trying to say that if you had COVID, then your body had the antigens to fight it off. But that wasn't always 100% true in a lot of cases. So they started doing antigen testing on patients to see if they had what they needed to fight off COVID, which made no sense because if they already had COVID, why do you care about the antigens at that point? But anyway, who am I? The spleen is located on the left side of the stomach, is a reservoir for blood cells. It produces lymphocytes involved in fighting infection. The hemic and lymphatic systems have conditions that affect the body, such as this list: lymphoma, lymphadenitis, hypersplenism, splenic rupture, that's deadly, and then leukemia, which, is very serious. Excuse me. um, Lymphadenitis is, simply swollen lymph nodes. A splenectomy. So a splenectomy can be performed. It's surgical removal of the spleen and is done when there's trauma to that part of the body. So if they can save a portion of it, they will try to. But if not, then they will have to do a total splenectomy versus doing a partial splenectomy. Or they can do a total with extensive disease, like if the person has, cancer or something like that, then they'll just totally remove it versus trying to keep a portion of it. A splenophraphy is if the spleen is ruptured, again, due to trauma, and they want to repair it, they can just sew it back together. Ain't that something? But a lot of times they will do that with or without a partial splenectomy, where they'll just take off the damaged part and then they'll still use the suture to kind of cut off the edges of it so it won't bleed, to close the edges of it rather. So, to avoid so much bleeding. Um, Bone marrow or stem cell services are utilized for bone marrow transplant, and that was the other transplant. So this is typically treatment for patients with blood diseases like leukemia. The bone marrow is obtained by aspiration or bone marrow biopsy or harvesting. Um, I've seen, this done on patients a couple of times just from, having access to watch the surgeries. And it is, depending on how they need to extract the bone marrow, they, um, they can't put the patient fully to sleep. It's weird. I can't even explain it, but it's painful as all get out because they're typically putting this needle in your bone, and these needles, the ones that they use for biopsy tissue, they are not small. Um, so it could be an allogenic bone marrow transplant where they're getting the cells donated from a close relative, or it could be autologous where they're taking bone marrow from the patient themselves, maybe from an area that is healthier that has been tested to say it was okay to have that bone marrow, and they'll insert it into the places of the patient that need it. So it's I just, like I said, I get so amazed with what they can do with our bodies. Our lymph nodes and lymphatic channels are a network of nodes that carry lymph throughout the body. It's a clear fluid containing infection fighting white blood cells. So typically, if somebody is fighting an infection and they have blood work done, their white blood cell count is going to be higher. Um, Drainage of a lymph node abscess can either be simple or extensive. It's simple if they, well, let me rephrase that. It's extensive if they have to drain it and leave tubes in, or do anything that is above the definition of simple. Biopsy or excision of lymph nodes are typical of what you've seen with biopsies and other organs of this respiratory system as well. So they could be either open or they could be by needle. And they could be superficial or deep. So if they're going deep, because again, we have lymph nodes everywhere. So there's some that are surface type lymph nodes, and then there's those ones that are deep, like deeper near the muscle tissue. And then a lymphadenectomy, if they're doing a limited, it removes only the lymph nodes. But if they're doing a radical, like we talked about with the mastectomy for breast cancer, they'll typically do a radical where they'll remove the lymph nodes, the glands, and surrounding tissues like under the armpits. And so that leaves little room for that cancer to spread. Last procedure, which lymph angiography. So ography or graphy is the suffix for when they're doing imaging. In this case, angio is blood vessels. So they're doing a lymph node of the blood vessels imaging. That's how you would kind of break that down. Excuse me. Goodness. So just remember that anytime you see graphy, that means they're doing imaging. And this one is for the purpose of seeing the circulation of the lymph fluid and how it's traveling through the body, if there's anything preventing it from being able to travel as normally as it should. So that's actually the end of the presentation. And while we did not get to do any exercises tonight, I feel like the information and the breakdown of anatomy and just kind of going over some of the procedures was helpful in helping y'all to be able to code the CPT codes appropriately. Just remember that you can use that section of your CPT book to start to really get familiar with your suffixes if you haven't for your surgeries, because that's also going to be very helpful with helping you go to the index. Like you'll know, if you see a lymph angiography, that is imaging, or if you see a thoracostomy, that was cutting into the thorax, or ostomy was creating an artificial opening. And once you really become so familiar with that, that's going to help you in the rest of the organ systems going forward. Any questions before we leave tonight?